Good day to everyone. I'd like to thank our partners from Fresenius and also from East Avenue Medical Center for an opportunity to briefly share about renal nutrition. So these are my disclosures, and thank you to these groups for helping me create the lecture. So we're quite familiar with the COVID-15 or pandemic 15 wherein we gained 15 pounds because of this quarantine, and we went looking something like this when we really wanted to look like this. As such, for a lot of people, nutrition has been a focus. A lot of us would want to avoid the carbohydrate and focus more on the protein for better body composition. However, we need to remember that a balanced diet is important so that we will not stress out our excretory system, particularly our kidneys, because protein contributes a lot to chronic kidney disease. So at the end of the 15 minutes, I hope I'll be able to discuss the following with you: CKD epidemiology, protein energy malnutrition and chronic kidney disease, nutrition in CKD, and maybe a bit on creating a nutritional dietary plan. So chronic kidney disease occurs in 1 in 10 in the population, affecting more people and more women, commonly because of hypertension and diabetes. And if we take a look at the dialysis patients, around three-fourths of them have CKD because of hypertension and diabetes combined. So our kidneys change from this healthy looking to this very shrunken aged kidney because of the disease conditions present. And if the kidney is affected, their functions such as filtration, water balance, prevention of anemia, acid base balance, and calcium and phosphorus balance or bone health are also severely affected. So as such, we should be able to protect our kidney in order to keep the functions intact. Now, how does the kidney essentially work? So essentially, we have our blood with the waste products going into our kidney, and our kidney is in charge of discriminating the substances to be kept, such as albumin, blood products, maybe a bit of the sugar. These are the things that our body needs, and the things that would be thrown out, like excess waste products, creatinine, maybe the excess electrolytes, or maybe some of the poisons or toxins that we have in our body. But if our kidney is very confused and is not able to do that, we will be able to throw out the things that we need, like our blood, our albumin, so we can see that in the deranged urinalysis, and the creatinine or the waste products will be kept inside our body. So this is very obviously seen in the Kidoki guide for chronic kidney disease, wherein CKD progression is measured both by the filtration capacity of the kidney and the throwing out of the albumin. So if we're not able to filter our waste products very well, like for example, from 90 ml per minute, the filtration capacity eventually goes down to less than 15 ml per minute. We need an outside source or an outside kidney in order to filter out what the kidney is not able to do so in the form of dialysis. In terms of albuminuria, albumin is like a big substance, and if it goes through our kidney or the filter is destroyed. Other than that, we lose a lot of the protein that we need for nutrition. So if we notice as chronic kidney disease progresses, albuminuria also progresses. And then the red bars here, which show the intersection of the GFR decline and the albuminuria increase, would point to an increased risk of continuous renal replacement therapy or dialysis. So protein is very important. The way that I explain this to my patients is that our body is like a car. So what happens is that the gasoline has two purposes or two outcomes in our body. So first, it can help the car move well. In our case, the protein helps our body function well in terms of exercise, creating our muscles, our cells, and the part that our body is not able to use or in the car, yung lumalabas sa tambucho or yung uso, would be the waste products also present in our body, which would need to go out in the urine. Now, if our kidney is not able to take out the waste products very well, the waste products would increase, and you would have an increase in creatinine, which is the measure of the waste product. This would cause pain, fatigue, sleepiness, pruritus, concentration difficulty, and the last two are particularly important in nutrition. We have anorexia and nausea. So we already have the weakness, and then we can't absorb what we need for our bodies to fix itself. Now, renal disease in the Philippines has been increasing by about 10 to 15% every year, and the number of dialysis patients has also been increasing. Now, the common cause, as we mentioned, is hypertension and diabetes. So these two are lifestyle diseases and greatly affected by diet. So many of the doctors and the patients, in order to prevent progression of kidney disease, would restrict, but too much restriction can also cause malnutrition. By the time the patients reach dialysis, in the study done in 2013 by the group of Divina, around 75% of the patients in the four hemo units were malnourished. Around half of them were severely malnourished. This can be seen in our protein, energy malnutrition, muscle wasting, and increased frailty. So why does this happen? So there are a number of factors. Firstly, we can have an increased albumin or protein loss as we proceed from A1 to A3 stage of chronic kidney disease. And this contributes to our inability to eat, the increased catabolic rate because of the disease, and then the increasing uremia and inflammation caused by the inability to filter the waste products will will give difficulty for the body to absorb the nutrition. Now the body will use up the muscles, and there will be sarcopenia and cachexia because they need the protein if they're not eating well, and this can contribute to an early death. So we need to avoid this by proper protein management, not too much and not too little. So, proper protein and dietary management will make use of the reverse epidemiology of obesity and dyslipidemia in CKD. In essence, what this means is that the body mass index and survival rate are linked. However, the way that they are linked differ from the general population to patients with chronic kidney disease. For the general population, in essence, the fatter you are, the more prone you are to die soon. But in chronic kidney disease, obesity is protective. Other than that, um, proper protein intake can prevent frailty among our patients. Dietary therapy will help with our management of our phosphorus, bone health, and then it also helps in the maintenance of our acid-base homeostasis because if you remember, proteins are made of amino acids. So much of our amine groups contribute to the BUN creatinine, and the acid part contributes also to our acid-base balance. So this should be controlled. And then also proper protein will help us with our exercise, and proper protein amount will also help us with our uric acid control because many of the uric acid sources are also protein. So renal nutrition management means aims to maintain or improve nutritional status, protect our lean body mass, control uremic symptoms, and maintain and improve the quality of life. So for us nephrologists, this is really the goal. So protein, the renal dietary prescription would focus on our protein, but also on the other electrolytes that are present in the body. So for nutritional assessment, this is quite important that in fact the KDOKI has the nutritional practice guide. You can take a look at this. The newest one came out in 2020, wherein it says that nutritional screening is important at least biannually. And then we have different tools. We can include history of the appetite, intake, body mass index, biochemical data such as albumin, anthropometrics, and physical findings in the patients when they're also starting on dialysis. So other than this, the timeline that we have for nutritional assessment would be every 6 months for early CKD, every 3 months for advanced CKD, and monthly for our dialysis patients. Now, the Philippine Society for Nutrition would also have this nutritional assessment form wherein they have weight gain, food intake, GI symptoms, functional capacity, disease, and physical examination findings. But for me, it's pretty cumbersome. So I just do the nutritional checklist wherein I ask the patient if he's underweight, if there's been weight loss in the past 3 months, reduced intake, or if the patient is ill. And if there is yes, if my hospital has a nutrition facility, we can refer or I go deeper into it in the history. So nutritional therapy, we order this commonly, uremic, renal diet, low, low, low. But maybe it would be helpful for us to put in some numbers, and I hope to review with you how we do that today. This is because protein is very important in CKD. In fact, chronic kidney disease is the only condition where protein restriction is treatment. So we need to know how to prescribe this for our patients. If we notice the progression is that if we are normal, we can have 1 gram per kilo per day of protein, but this would eventually decrease in advanced chronic kidney disease where we advise zero point 0.6 to zero point 0.8 for low protein, or a very low protein of less than 0.6 gram per kilo would be supplemented with essential amino acids or keto acids. And then eventually on dialysis days, if the patient's already on dialysis, we would increase the protein again because protein is lost in the bloodlines during hemodialysis or in peritoneal dialysis. But you should also focus on the other micronutrients. So for sodium and potassium, the magic number is 3, less than 3, especially in potassium if there's hyperkalemia. In phosphorus and calcium, I usually just memorize 800. So zero point 0.6 to zero point 0.8, 3 for sodium and potassium, 800 for phosphorus and calcium. So this is quite similar to our local data, which was published in 2010. And then I'd like to emphasize why low protein is important. So the pathophysiology is that in the glomerulus, or the filtering unit of the nephron, we have two blood vessels, the afferent going into the glomerulus and the efferent exiting. So our goal is to decrease the toxins and the increased pressure here, because increased pressure would destroy the glomerulus. Low protein has been found to close off the blood vessel going into the glomerulus and open up the blood vessel exiting the glomerulus. So less blood going in and more blood going out, lessening the pressure so that the glomerulus will not be stressed out. This is quite the opposite of increased protein intake. So you would have glomerular hyperfiltration, more fluid going in and less exiting out. And this increased pressure would destroy our nephrons. So as such, we would have these different guides. We emphasize on low protein for advanced chronic kidney disease. Now, for the dietary prescription, we begin with the number of calories per day, where the group of Kalantarzade would emphasize 30 to 35 um, kilocalories per kilo per day. So we usually would just tell the patient, if we convert this to grams, there are different hand measures that we can do in OPD to help them out. So you can take a photo of this. So we would need also to limit protein, and in the same way also limit purine in the diet. So these are the different food groups that we say: less beer, less red meat or red fish, organ meat or lamang loob, and then small fish and shellfish. Now, other than the protein, so you start with 0.6 to zero point 0.8, for example, in advanced CKD, then you would move on to the other macronutrients like the carbohydrates and the fats. So example is, we can say, for the non-protein caloric requirement, we would have 60% carbohydrate and 40% fat, just as an example. And then the meal type would be 3 meals and 2 snacks if our patient is admitted, authorized feeding. And then we focus on the other electrolytes. So for sodium, it's less than 3 grams per day. So if we recall, sodium is normally present in cooked food and beverage, mostly in table salt. And I advise the patient 1/4 teaspoon is usually 500 milligram of sodium. So if the requirement of sodium is less than 2 grams per day, 1 teaspoon of salt per day should be given. So avoid fast food and processed food because this has high salt content. And this table would focus on the different sodium contents of the different condiments that we have. So we can just give a bit of the barbecue and the mustard maybe instead of soy sauce. So other than this, maybe it would be helpful to avoid fast and processed food. We can use spices, lemon juice, and calamansi. And I'd like to zero in on the different sodium contents of the different canned food. So here we have tuna, corned beef, and then a whopping 1,160 grams of sodium for 100 grams of pork luncheon meat. So if your patient consumes this, it will be pretty difficult. Now for potassium, it's around less than 3 per day. And then we can lessen potassium by limiting our fruits and vegetables if our patient is hyperkalemic, or maybe double boiling or leaching our potassium sources. So the potassium will be leached out in the fluid. We can throw them out if the patient really wants to eat our vegetables. It should be very well cooked. So potassium monitoring is key so that we know whether to restrict or to give more. Phosphorus and calcium would emphasize around 800 milligram per day. And if you remember, they are found mostly also in protein-rich food, and phosphorus is added in many colas, fast food, and processed food. And this must be monitored regularly. So phosphorus is highly found in crab meat, bilis, tulya, beans and nuts, spare ribs, etc. And lower foods in phosphorus are the galunggong, tilapia, salay-salay, and lapu-lapu. So these are different options for our patient. So for the patient, when we tell them ano yung dapat kainin, we can use the pinggang CKD, wherein we note that we have a 9-inch plate and half of this would be vegetables, and then around greater than a fourth would be carbohydrate, and then less than a fourth would be protein. And then for dialysis patients, we can increase the protein already. So we can also use other tools like MyFitnessPal, wherein we see also the protein that is present if we log in our foods. So that's it. At the end of the 15 minutes, I was hopefully able to present the following objectives. Thank you and good day.